Hello, and welcome to Preemie Chats, a place for parents and healthcare professionals to gather, share stories, and learn from each other. My name is Jenna Morton. I'm one of 3 co-hosts who present this weekly series on behalf of the Canadian Premature Babies Foundation. I am a career broadcast journalist and mom to 3 NICU grads, including preemie twins who were born at 32 weeks and are now 12 years old. I live and work in Mi'kma'ki, outside of Moncton, New Brunswick. Well, Preemie Chats is the creation of the Canadian Premature Babies Foundation. The foundation is a parent-led charity that helps families during and after their NICU time through education, support, and advocacy. You can see our website there on your screen, canadianpreemies.org. I hope that you will take some time after our discussion today to visit it. You'll find all kinds of resources. You will find replays of our preemie chats from the last several years. After today's discussion, you'll be able to find this one there as well. Most importantly, on the website, you will find a community of parents and professionals who are working together to help our children thrive. Well, I would love to know where you are watching from today. Let us know where you're tuning in from and what brings you to Preemie Chats, whether you are a healthcare professional, a preemie, a parent of the preemie, whatever brings you to us. We'd love to know why you're here and where you're watching from today. And as we go through, please do feel free to engage in the comments, to share your stories, and to ask questions. Before we begin today's discussion, I'm just going to take a quick moment to highlight that the discussion today is primarily centered around loss, and that it's presented mostly with healthcare professionals in mind, as well as parents. So if you are someone who personally has dealt with pregnancy or infant loss, if you're pregnant and you're very worried about outcomes, this may be a bit of a difficult conversation to listen to. So please take care. If you're worried about that, you can stop watching now. You can always come back and watch the replay when you have control over what you hear and when you stop. But I hope that a lot of you will stay with us and enjoy this presentation, because I think it's a very important one with some fantastic information that we're going to go through today with our guest. So much about pregnancy and parenting is uncertain. And yet we often find ourselves avoiding those uncomfortable feelings and those discussions that come with not knowing exactly how things will unfold. And in the world of caring for complex pregnancies and births, it's incredibly important that healthcare professionals are prepared for these difficult conversations with families. And our guest today is trying to do just that. Dr. Nicholas Embleton has worked in neonatal medicine for nearly 3 decades. He's a consultant in neonatal pediatrics at one of the largest NICUs in the UK, and he teaches neonatal medicine at Newcastle University. He's known for his research on many topics, including nutrition and gut health, as well as his work around the topic of baby loss, including creating a course to help other healthcare professionals approach difficult conversations with families. And that's where we're going to begin our conversation today with Dr. Nick. Welcome to Preemie Chats.
Thank you, Jenna. Nice to meet you.
It's very nice to meet you and to have you with us. And I'm really looking forward to hearing more about this course and what you have to share with people. I had an opportunity to take the first half of the course online. It was very eye-opening, even as a parent. So I'm really looking forward to this.
Good.
So I'm going to kind of turn the screen over to you for a little bit and sit back and listen along with everyone else.
Okay. Thank you very much. So thank you again for the kind introduction and the welcome back to Preemie Chats. I had a chat probably 2-3 years back on one of the other topics that I've been interested in, which is baby loss within the context of a twin or triplet pregnancy. And today what I want to do is share the topic of managing uncertainty that we have developed an online learning course for. This is a 4-hour learning course. And so what I'm going to do in the next 15-20 minutes is just take you through what the course covers. I'm not going to go into any of the topics in any great detail, but I want just to give you a kind of preview of what the course looks like, give you an idea of the kind of media, the format that we use, and some of the topics. And then very happy to take any questions. The course is really aimed at healthcare professionals, but I know that already in the 2 months since we've had it running, that several parents have looked at it and engaged with it, but also people from outside of healthcare professions, so people perhaps from teaching, education backgrounds have also engaged with it. So the course is called Managing Uncertainty in Perinatal Medicine and Palliative Care. And one of the kind of critical features of the work that we do as neonatologists, but also the work that is done in fetal medicine, antenatal and postnatal care, all of us really recognize how much of the issues we face and the families we work with require us to deal with uncertainty. And I don't think there are any areas of medicine that are really as uncertain as the challenges that we face in neonatal and perinatal medicine. And examples might be babies in utero or after delivery who have complex genetic or syndromal problems. It may be pregnancies affected by growth restriction and decisions that might need to be made early on in the pregnancy about continuing the pregnancy. And it may be uncertainty that arises in the context of caring for a newborn baby who is unexpectedly sick, so maybe a baby with an undiagnosed congenital problem, or a baby born with hypoxic, ischemic encephalopathy, so lack of oxygen. So uncertainty may come from many different routes. And what we wanted to do was to try and provide a basic kind of teaching package for this, recognizing that all of us at some point in time have to deal with it. So as I say, I'm going to take you through the course and show you what's in it, then I'll take any questions. And so at the outset, I want to point out that although I led the development of this, I worked very closely with Alex Mancini, who is the lead neonatal nurse nationally for palliative care. And then a large group of health professionals, nurses, hospice workers, psychologists, and also parents who've shared their stories and made videos with us. And we've also been supported by a number of advocacy and charity organisations working in the neonatal space, but also the baby loss space, including Canadian Preemies Foundation, who've also lended their support. So I'm presenting on behalf of a very large group. The course is available on a platform that could charge you a fee, but I want to point out I don't get paid for any of this, and none of the money that is raised comes back to me or any of the other workers. And also just point out again that I'm talking about baby loss and making decisions about babies during pregnancy or after delivery. And we also discuss how we might care and support for families dealing with the prospect of their baby dying or supporting them after death. So this is an incredibly emotional topic, and some of you will find this quite triggering. So, as I say, again, just to kind of point out that the course is available on this platform called FutureLearn. I'll give you a link to it at the end of the course. FutureLearn is an educational platform. It's not set up specifically to provide training for healthcare professionals, but it's a nice format for online learning. And again, just to point out that there are lots of important advocacy organizations that have been supporting our work. And then just a very brief advertorial for another global online resource, which has been developed by the Global Foundation for Care of Newborn Infants. And this is an encyclopedia aimed at parents, explaining a lot of the terminology that appears in neonatology. So I just want to put a plug to that because that's only come out in the last few weeks. And I was one of the experts who helped contribute to it. So this is what you would see when you go to the FutureLearn platform to find this course. Once you've found the course, you'll see that they might suggest charging you a fee. So you can join FutureLearn and get access to lots and lots of courses, and some of you might want to do that. Or you can buy this course, which allows you to access it for as long as you want. But I really want to highlight this option to you, which is a free option, but you need to scan to the bottom of the starting page to find it. But this allows you free access for 4 weeks. So any of you on the call today or who listen in who want to do this course, you can access this for free. And that's the QR code that will take you to the course on FutureLearn. So as I say, they don't make it easy for you to find the free option, but there is one if you scroll down to the bottom. And once you've done that, it allows you to engage with the course fully, but you won't get a certificate without paying the upgrade. And so what do we cover in the course? Well, we start off by briefly describing the kind of complex fetal neonatal conditions that might lead to uncertainty. We give some advice and good practice around listening to parents and communication challenges. We give some markers of how to work as part of a multidisciplinary team. We discuss some of the ethical challenges and the aspects of memory making, advanced care plans, and also transition within the course. And by the end of the course, learners will be able to demonstrate an understanding of the experiences of parents faced with a baby who may have a very uncertain future or a short life, help you access other resources. So this is the broad kind of syllabus that we've tried to lay out. And then when you go to the course, it starts off by just asking you what your background is, and some of this writing is too small, don't worry, but it does show you that we've already engaged with a variety of healthcare professionals, nurses, doctors, psychologists, nurses, students, but also other people. And the course is made up of a series of weeks. Again, don't worry if you can't see these in great detail, but each week is broken down into a series of short steps, and each of these steps would take you about 4 or 5 minutes to complete. And these steps might be videos or short text discussions, but they might be audios and these things. So we use a variety of media. And we've tried very hard to make this a very kind of graphical course, to make it quite engaging online. And so as an example in this step here, we really start off by raising the question, how would you know that you were dealing with a baby who may have an uncertain future? And this might be because the baby or fetus has received a diagnosis that makes it likely the baby might have a short life or a very uncertain future. So this might, an example of this might be a baby during pregnancy who's diagnosed with a trisomy. But other ways you may become aware of babies with an uncertain future would be if there's a concern raised by the multidisciplinary team. So, you know, a baby born at 23, 24 weeks would be a great example of this. And the third way we might become aware of babies with an uncertain future would be what we call the surprise question. And this would be, would it be a surprise if this baby suddenly died? And if you ask yourself that question of fetuses or babies you're looking after, it might also identify babies who might require a more kind of palliative care approach. And I don't want to get trapped in terminology, because all of you will understand the meaning of the term palliative care in a different way. For a lot of people, palliative care, and for a lot of parents, palliative care might feel like a form of care where you're giving up on active treatment and you're just getting ready for the baby to pass. But we really want to emphasize that palliative care encompasses active treatment aimed at sustaining life through any means, intensive care. But what palliative care does is encourage us to think and recognize that there is uncertainty here. So on the one hand, you may have, survival focused care where everything is just about the intensive care. And at the other end, people might think of palliative care just about end of life care. But the truth is, what we are doing in neonatal medicine, perinatal medicine, is really dealing with the intersection of these two, and the importance of providing family support and what we call parallel planning, but also recognizing the importance of end-of-life care, bereavement, loss, and these aspects. So terminology differs between different units, different populations, different cultures. All of us understand perhaps these meanings differently. So when we're using these words with parents, we should be clear what we mean by it. Palliative care to many feels scary, a bit like you're giving up. And what we're trying to do in this course is promote a practice and approach rather than recommend the use of certain terms. And being honest as a neonatologist, as a fetal medicine specialist, being honest about uncertainty requires all of us to adopt what we call a parallel plan approach. So in green here, you will see that perhaps what we call the traditional linear approach was a doctor saying, look, just trust me, we're going to do our best for our baby, you crack on and do intensive care. But then you're faced with a situation where you think, well, this isn't working out. Then you think, well, we better do some palliative care, do some memory making, and switch to end-of-life care. That's the kind of traditional linear approach. What we're recommending here is really a parallel planning approach from the very first minute, or the very first point in time that you have an antenatal ultrasound. And this should start off with us as professionals being honest, saying to parents, I think he's going to survive, but I don't know. Or I think he won't survive, but I might be wrong. And then parallel planning to do intensive care, palliative care, and family integrated care all at the same time. And all of this will lead to a whole set of different outcomes, perhaps survival and long-term follow-up, perhaps palliative care outside hospital, end-of-life care, but also bereavement care or trauma support and debriefing. So parallel planning is at the core of what we're trying to do here. And we developed the course through case studies. So on the left here is a case study where at 18 weeks, the mother and father have been faced with a diagnosis following an amniocentesis that's confirmed trisomy 18, and how you might approach that as the neonatal or fetal medicine consultant. And throughout the course, we developed these 5 key areas of palliative care: the importance of support for parents and families, the importance of empowering parents and families to be actively involved, how we plan together, how we treat together, and then how we deal with aspects of loss. And you won't be able to see these 3 weeks laid out in detail, but this just gives you an idea that we move through these various topics and themes over a 3-week period. And in these 4 weeks of the course, we deal with how to have conversations, the importance of continuity of care, how we recognize babies, what we mean by compassionate leadership and parallel planning, how we work with interpreters, how we deal with some of the ethical aspects in care after death. And we do this by using graphics, text, video, audio, but also importantly, encouraging discussion with peers in the course. And these peer conversations, I think, are what really make this course unique compared to different platforms, because it allows everybody who engages to contribute their own ideas or experience. And so in this step, we posed a question about how people might approach this case. And then you get to read what people would do. So here this person's talking about what are the family hopes for Jake? How would we plan early care and logistics? Also, I would talk with colleagues. So just sharing opinions. And this is really, for me, one of the best aspects, just listening and learning from other people. So these are what we call kind of conversations or discussions. And they allow people to pose questions, but also to share insights and share their knowledge. Some of you on this call presumably will be quite experienced. And then we deal with some of the key aspects of having antenatal conversations, making sure that you understand the facts before you go in, how to explore parental knowledge uncertainty, the importance of helping parents feel in control, building trust and rapport, acting authentically, exploring parents' values, and obviously considering different cultural backgrounds. So we provide some teaching and learning around these aspects. And how a conversation with a parent, perhaps in an antenatal clinic or on a neonatal unit, how these conversations might develop. And this might be a sort of an aid memoir of how physicians might conduct the conversation and the various elements that we might need to be aware of. And as I say, throughout the course, we want to emphasize that palliative care is an active approach. This is not an approach which is just about controlling symptoms and allowing babies to die. This is very much saying we need a parallel approach. We need to recognize the inherent uncertainty in many of the conditions we're dealing with. We need to recognize that many of our babies are at high risk of dying, but the majority we're treating with the hope that they are going to survive. So parallel planning, palliative care is compatible with planning and providing full intensive care whilst acknowledging that death is a real possibility. And this encourages us to think about these very important aspects, that the parent journey that they're going through, the importance of memory making, family integrated care, spending time with your fetus and baby, but also being open and honest. And we then talk about how you might develop these conversations either in an antenatal clinic or in a neonatal unit environment, how we work through the various possible options and outcomes, exploring parents' knowledge, thinking about how and where we conduct these conversations, what are the elements of having a sensitive conversation like this. We also give some guidance and advice about how you could start these conversations. I mean, this is a very difficult conversation to have, and many physicians feel quite anxious about this. So on the left here, we have these 5 key kind of questions that we think are quite good about helping start some of these conversations. You know, tell me about your baby. Tell me what you've been told already. What is it your most hopeful fear? What is it your most fearful fear? What do I need to know from you that might help me guide you? So that's one way of doing it. Another kind of way of doing it, another kind of schematic is this kind of wish, worry, wonder thing. You know, what is it you wish for your baby? What is it that you worry about? And then for us as a physician to pose, I wonder if it would be helpful to think through what would happen if Keith becomes more unwell. We want to emphasize the importance of appropriate or culturally sensitive palliative care. And again, I think we've moved on in this in the last 10 years or so. So this is now all about cultural humility, much more so than kind of cultural knowledge. It's impossible for me as a physician to know anything about the wide diversity of different religions, cultures, and beliefs that are out there. I can't possibly know this. And if I try and learn it and believe that there's one approach for Christians and one approach for Muslims, you're going to get yourself tied in a terrible mess. So here we suggest some questions that might help you explore this with your families. Is there anything related to your culture or religion that we should know about so that we can care for you and your baby? Would it help to talk to a spiritual leader about how you're feeling? So we provide a bit of guidance, some of the things that we ourselves as experienced physicians have used in our practice. We want to encourage everyone doing the course to kind of challenge their own assumptions and biases. Do they know about their own populations? if you're a person of color, does that impact on how you practice? If you're a white European person, does this impact? So we want to encourage people to think through that. We provide some practical advice about working with interpreters, the importance of the words and phrases we use, and we provide this schematic, arranging the interpreting session, briefing the interpreter, the interview itself, debriefing with the interpreter, and then evaluating it. And I think most of us do the interview bit, but don't really think about the other aspects of it at all. So we provide some guidance there. We give some examples of how you might want to word a letter to parents or word an advanced care plan. So here we just give some examples of how we've written letters, not suggesting that you use the same form of words, but just to give you ideas of how we do it that you might want to take some of the elements from. Continuity of care is really important, obviously, when we're dealing with these difficult situations. I think we're kind of quite aware of the importance of informational continuity. Do we all have the same information? We're probably fairly good most of the time about management continuity, but maybe we're not so good at relational continuity. I mean, how is the relationship that I've developed with this parent going to be taken on board by the physician who looks after the baby next week? We discussed some of the principles of neonatal end-of-life care, the importance of considering other family members, particularly siblings, importance of emotional, psychological support, and symptom management. And then we have some examples of videos, and I can't play these with you today, but you can see these videos. But one of the things that I really wanted to do in this course was get us to listen to the parents. And so on the right here, you see this mum whose baby sadly died from hypoxic ischemic encephalopathy. She's written a book. And there's a short 3-4 minute video there with her talking about her experience that is incredibly powerful. I've listened to it several times, and every time it strikes me. So I think this is a really unique course that there isn't anything really else like that out there. It's putting together years of experience, not just from me, but from lots of other health professionals from many different disciplines. And as I say, it's available for free. And you can access it by going to FutureLearn and searching for it. Either just go to FutureLearn and search, or just this is the actual name of the course. There's a different link for people from the UK NHS if they want to go through this link. And already we've been able to engage with almost 300 health professionals from about 50 different countries already, but we've only been out there for 7 or 8 weeks so far. So that's already on a good roll. And then finally, just to finish, highlight that I have these 2 other courses that I've also developed, one of which is providing an advice and support around lactation after loss and raising the possibility that there are a number of women who may want to continue lactating after their baby died in order that they can donate their milk in memory of their baby. So that's a 2-hour course there. And then, of course, around another project that some of you may have been aware of, which is the Butterfly Project, supporting families who lose a baby from a multiple pregnancy. So thank you very much for your time. Delighted to take any questions and listen to what you have to say. So thank you very much.
Well, thank you so much for giving that overview of the course. Again, there's so much fantastic information that you've compiled there. One thing that I wanted to mention when I was going through the first part of the course, when I was doing it, that really stood out for me was a portion where you talked about, how you build those relationships with parents and the small steps that, only take a moment to do that can have such an impact, like asking, do you mind me asking if you've named your baby yet, or if you know the gender? And it was so powerful to me when I was going through that part of the course. I was like, oh, I remember that moment of having a complex pregnancy and having that, we need to name these babies. And I know some people are the exact opposite and they don't want to. And so taking the time to ask the question rather than assume something or avoid it altogether because you're not comfortable with that uncertainty.
I think when I first started out, all physicians are are anxious about these conversations. These are the most important conversations we ever have in our careers, because depending on how we explain the situation, parents are going to make a decision that may result in the end of that pregnancy or the death of the baby. And I always wanted to try and make those conversations least stressful. I don't enjoy stress. And I found that just trying to be a little bit more human about it all, just walking in there, introducing myself, of course, being professional. And as you say, asking this question, do you mind me asking, do you know if you've got a boy or a girl? And most parents want to share that with me. A small minority say, no, we don't want to know, and it's fine. You know, you move on. But most parents say, yeah, we have a little boy. And then that gives me an opportunity to say to them, I'll say, oh, okay, has he got a name? And again, most parents are happy to share the name. Not all parents, and some parents haven't decided to name the baby. But I think it shows parents that I'm a human being, and I want to be interested in their baby as a baby, and not a medical diagnosis or problem.
And I think it's so powerful for people who are in the healthcare profession to have that example and that realization that you can do both. You can have that personal touch without losing that sense of, I do have some authority here. I do have some knowledge that I can share with you to help you make the decision. But it doesn't have to just be that linear approach that you showed that was so traditional for some people.
Yeah. And I think we've all, in the past, I think we were scared of these conversations, if I'm honest. Most physicians don't go into medicine with the intention of having these difficult conversations. We go into it because it looks kind of interesting to be a doctor and look after complex babies. And so this isn't something that necessarily is taught very well at med school and even during kind of residency and training. And most of us have had to pick it up along the way, and most of us have put our foot in it probably several times. But I was always very, I think, reflective and thought, oh, that didn't work out, I need to do it better next time. As I say, you can tell from my grey whiskers that I got to the end of my career and I thought, I should probably put this down in a form that other people can benefit from, because I think along the years, along with all the other people who've contributed to the course, I think we just learned lots of little tips and advice that we want to share with other people.
I was wondering if you could talk to that a little bit about, for people who are watching this, it's a good chance they're early in their career as a healthcare provider, and to give them some advice to, how you deal with those feelings of coming out of one of those conversations and going, oh, I should have said this, or I could have done this, because I'm sure that happens. I mean, that happens to all of us in general conversation.
Yeah. I think we just all need to be humble. Let's be honest. There are a lot of very arrogant physicians out there, and we all like to think we know it all. Me included, like, oh, I know all this. I'm a very important person. Like, we just need to be humble and realize, like, we're not always going to get it right, and we should be able to learn. I mean, even in your third, fourth decade, you should still be learning and realizing how you could do things better next time, and then finding ways to share and teach that knowledge. So I think, important to recognize we should all be working in active learning environments. We shouldn't have this idea that, you get taught and then you just keep on doing it. So all of us should approach this. All of us should recognize that it's okay to be a human being. I mean, I don't think we should be able to deal with these very difficult conversations and this uncertainty without ourselves feeling a little bit upset by it. I mean, it would be weird if you could be a pediatrician, neonatologist, and have a conversation about a baby dying and not be upset by it. I mean, that would be a bit strange. I mean, that's not natural. But just because you can empathize and feel that pain and sorrow doesn't mean you have to stop being professional. So it is about getting that balance right. And as I say, I think physicians would be helped by being encouraged just to lean into it a little bit more. I'm not a touchy-feely person. You might think that because I'm a touchy-feely person, I've done this course. Absolutely not. I mean, people would say I'm probably the complete opposite. But I recognize the importance of how you make these relationships with parents. And if you can make good relationships with parents, and you do that often by showing that you really care about the challenges they're going through, they're much more likely to trust you. And then when you do need to have these difficult conversations where I say, honestly, I'm really sorry, I don't think this is going to work out. We need to start thinking whether what we're doing is really appropriate. Parents will trust me. Where parents don't think I care, and I come along and say, I'm not sure we should be doing this, that they're going to find it much more difficult to engage with me and make a decision that's in their baby's best interest. So yeah, I can't emphasize enough the importance of trying to get those conversations right. And during a conversation, you know, there have been occasions where I said something and I've thought immediately, oh my God, like, you idiot, why did you say that? And again, like, you know, we're all human. And what I learned is to say, oh, you know, I say something and then I think, oh no, I said, look, I'm really sorry. I was like, I didn't explain it very well. Can I just go back again? Parents say, yeah, sure, fine. Like, don't try and cover it up. Like, you know, we might make mistakes. We might use the wrong word. We might, I don't know. I've got babies' names wrong before. Right? Like, you know, if you make a mistake, just hold your hand up, say, look, I'm really sorry, that didn't sound very nice, so I should have put it a bit differently. Like, we're just humans.
I think that's such an important thing for us all to remind ourselves from time to time. I'm going to share a couple of the comments from people who have been watching. Erin, who I think said she was in Dartmouth, if I remember correctly, Nova Scotia, just saying, you know, thank you, you know, especially, you know, I hear parents say that medical professionals push end of life when the diagnosis might be difficult for the parents in the future. And I think, you know, yeah, it's sometimes we need to hear things.
Yeah. I mean, you know, you can't be a good physician if you're not honest, and being honest sometimes means sharing really difficult information. And you know, if I think that this baby is unlikely to survive, I need to share that with parents. But at the same time, you know, I shouldn't be pushing parents to encourage them not to continue active treatment, just because I think that, you know, we might be faced with a very difficult situation in a week and a month's time. Doesn't mean I should be saying, well, look, let's just make it easier for ourselves. No, I mean, we have to recognize that there's some really, really difficult decisions. And they're not for me as an individual to make. Like, I work with part of a team, and I should never feel that I was the one to make this decision. Decision should be made with all of the other people in that team actively involved in that baby, with, of course, parents right at the center of that team. And that when you as that team are starting to struggle, well, then I need to ask even more people. I need to ask my other neonatal colleagues and other fetal medicine colleagues. None of us should be making these decisions on our own. That's not fair, and it doesn't result in the best decisions.
Yeah, and that making sure that the parents are at the center of those conversations is so powerful for parents to hear and know that there are healthcare professionals that are actively doing that now. Juliet, who shared in a previous comment, she's a preemie adult who was born in the 1980s, 28 weeks, talking about how powerful that is to, you know, the idea of using the baby's name, and some thoughts there that she's had from her father saying that it was very important. Surviving an hour and a half ambulance transportation, not knowing if she's going to survive.
Yeah, I mean, names are so important. You know, again, like, you know, recognizing diversity. There are, of course, some cultures where the babies are not named until they go home. Some babies are not named until they're a few weeks or months old. Some cultures where parents don't choose the name, but the elders in that community will choose the name. But you know, for the majority of parents we deal with, naming your baby is a very important bit. I mean, I've got 4 kids, and choosing their names felt like a really daunting thing. Oh my God, like, I'm giving them a name they've got to live with forever. So you feel this huge burden and responsibility, but it is what helps you form that baby's identity quite often. And we know that parents start making a relationship and identity with that baby from the minute the baby's conceived. You know, like, that's when your kind of relationship of love starts, before you've even seen them.
Juliet also had made another comment earlier. I just wanted to share about, you know, especially the importance of clarifying and talking about the definitions of words with patients, I think is so paramount. So many of us have those connotations of what something might mean. And if you don't know that it's different in the medical terminology, then you can really set up people for those.
Yeah, and I think that kind of medical terminology will vary between countries, and probably, you know, the majority of healthcare professionals in Canada might understand these terms to mean something different to my neonatal community in the UK. I mean, you know, we feel we understand these terms differently to adults. So this is difficult. That's why I say, like, we don't want to get too hung up on the actual word you use. And if you say, I think we should adopt a palliative care approach to parents, you need to explain what we mean by that. And what we mean by that is being very aware of the fact that this baby might live a short life, being very aware of the fact that they may die. Therefore, it's really important to start memory making and helping parents build relationships and positive memories right from the beginning, and not just at the point where you think, oh, they're not going to survive and let's do it now. So really, that's what we're trying to promote is you know, what we've always known, which is the future is uncertain for many of these babies.
And on that point, Sandy had a question that she's asked about, you know, kind of deciding how do you come to those points? Is it a, you know, a gestation smaller than a certain number of weeks? Is it diagnosis? You know, how do you decide when you're going to make that?
What we kind of use in the course is these kind of 3 different ways. So the first might be where the baby has a specific medical diagnosis that is associated with a short life or a high chance of dying in infancy. So that will be your, you know, trisomy 18, 13, you'll be your 22 weekers, it will be your babies with diaphragmatic hernias. But any baby who has a diagnosis where those babies might die, that's your first set of babies who you need to kind of consider a palliative care approach alongside an active approach. The other way that these babies might be identified as needing palliative care would be, for example, you're just doing rounds or handover, and, you know, somebody says to you, oh, this is the 4th time we've tried to take him off the ventilator and we haven't managed. Do you think he's going to make it? And we'll go, oh, right, you know, you're right. So sometimes these come out of a concern from the multidisciplinary team. And then you think, yeah, we should really be thinking about how we practice palliative care. And then, as I say, the last one would be what we call the surprise question. And you just go round the NICU and you look at a baby and someone says to you, would it be a surprise if this baby didn't survive? And, you know, you'll get different responses. Sometimes you go, no, I wouldn't be surprised at all. Well, you then definitely need to be doing palliative care. But what we're really trying to do is say, like, so much of what we do is uncertain. I mean, there are babies born at 34 weeks who don't survive. Now, I'm not suggesting we kind of start talking about palliative care to parents of 34 weekers, but every baby who needs any form of intensive care is at risk of not surviving. It might be incredibly rare at 34 weeks, but it's very common at 24 weeks. So we don't want to have any kind of cutoff that says, well, this is when you should do it, and this is when you. The doctors and nurses need to say, is this baby at risk of not surviving? If the answer is possibly, well, you need to think about encompassing palliative care principles.
I think, again, there's so much in that course that you've put together to help you think of those scenarios and try to think through before you're faced with them in person as to what you might be able to do in those different situations. Before we kind of wrap things up here today, I was just wondering if you could share a little bit about why you chose to do this course and this work.
Well, a few things came together. I mean, the British Association of Perinatal Medicine put together a working group on this a couple of years back and published a document. And I looked at this document and it's under 30 pages and it contains lots of great stuff. But I know that it's just going to sit on people's shelves and not be read. I really wanted to bring this to life. As I say, I've had a long and very enjoyable career, and I realized this has been one of the most challenging aspects for me. And I wanted to kind of, you know, share some of what I've learned over the years and what other people have learned, put it down somewhere. I mean, how are the next generation of residents and fellows going to know unless I tell them? So it's really about doing this. And then finally, it's really, I think I just started to realize the power of online teaching. I've been very lucky. I go to a lot of meetings, conferences. I get invited to go to lots of places. I put a lot of effort into preparing a kind of 40-minute lecture. I give it to a couple hundred people and that's it. And I thought, well, what a shame. I mean, there's not 200 people who might be interested. There might be 200,000. So really, this is about putting it all together that anybody around the world can access. You don't need to drive to study day. You don't need to get funding to take the day off, all this kind of stuff. It just, to me, seems a really efficient way. And the beauty of the Future Learn platform, as I say, is this ability to engage and listen to your peers. You know, I can put in a comment, I can read somebody else's comment, and I can reply to it, and I can say, oh, have you seen this book or this paper or whatever? So I really like that interactivity that you get on this platform. And as I say, like, I just like the idea that it's available for free, and then, you know, means that I've been able to provide online learning. I gave you some examples of the other courses, but we do get quite good engagement from health professionals from resource poor backgrounds who find it very difficult to access high quality learning. This is a platform that allows us to do it, and they can access it at zero cost.
Yeah, I think it's, like you say, it's so powerful. The platform's very easy to use. It's very, very interactive. You say there's video, there's audio, there's short bits of text. But then, like you say, in those comment sections is where you end up finding, you know, so much connection and realizing, you know, no one's really alone. And the same thing's happening in our comments there today. You know, Aaron sharing again, you know, talking about memory making and you know, different ideas of what you can do for that. You know, 12 years out, I still have things that our nurses made for our boys. I have things from, you know, when we were waiting to see if they would, you know, survive or not. And those things, they stay with you. And the more people can share that information with each other, the more that we help someone else. So I want to thank you for taking the time, not only to play a role in creating the course, but for sharing it with us here today.
You're welcome. Thank you.
Thank you so much. And thank you to everyone who's been sharing in the comments and watching online. My guest today was Dr. Nicholas Emblenton, and he is one of the creators of that online course, Managing Uncertainty in Perinatal Medicine and Palliative Care, which is available for free through futurelearn.com. And I did put the link directly to it in the comments there. So hopefully if you're able to if you're interested, you're able to just click on it. But if you go to futurelearn.com, you can search it up. A reminder to everyone that you will be able to find a replay of this discussion on our website, the Canadian Premature Babies Foundation, which you can find at canadianpreemies.org. All of our previous conversations are there as well. And it will remind you when you go there that the Canadian Preemies, the CPBF, is a charitable organization. And it's thanks to our sponsors and donors who support us that we're able to keep doing things like Preemie Chats. If you're able to, you can hit the donate button on the website. But most importantly, if you're able to hit share on this video or any of our other work and spread the word, that would mean the world to us. Thank you so much for watching. Preemie Chats does take place every Friday afternoon at 1 p.m. Eastern Time here on your social media channels. I hope you'll be back with us next week. And until then, take care.